So you can see we having a deep S wave, and you can have a Q in the pre and T wave inversion. Along with that, you have a signs of a RV strain, where your T wave inversions, incomplete right bundle, and late transition, such as you have RV dominance. So these are all can clinch your diagnosis of a pulmonary thromboembolism in a clinically suspected patient. So next patient is a 20-year-old preemie gravida, had a fever, jaundice, and altered sensorium for 5 days. GC sub 12/50. Blood smear was positive for falciparum malaria and has a high parasitic index. She was started on a quinine infusion. On day 2, patient developed a sudden hypotension with pressures of 80 with a heart rate of 200. So this is a ECG. You can see a ECG here. So down you can see very clearly patient is having something very classical. So you can see a white QRS tachycardia which is changing the axis. You can see it's a typical morphology you will see in the particular condition. When you see a polymorphic ventricular tachycardia which is changing the axis like this, we usually call them as tarsals. So this is a typical tarsals. So when you have polymorphic ventricular tachycardia in a background of a prolonged QT interval, we usually call them as a tarsal 3 pointers. So you can have a polymorphic ventricular tachycardia without QT prolongation also, but when you have a QT prolongation along with that, you can get this pattern. So you want to differentiate with how a monomorphic ventricular tachycardia looks like. This is again a ventricular tachycardia, again a white QRS tachycardia. You can see QRS is wide up. Whenever we tell white QRS tachycardia, your QRS width is more than 120 milliseconds. You have a QRS more than 120 milliseconds and a heart rate is more than 100, you call it as a white QRS tachycardia. So as I told earlier, every ECG has to be interpreted along with the clinical history and you should read the ECGs. Don't jump in the diagnosis. If I ask you to read the ECG, you will be saying me like rate is higher or calculate the rate is around 150 to 170, it's a tachycardia. Then you will see how regular it is. You will see it's a regular tachycardia because it's every QRS complex is regular. Then you will look at the QRS width and see it's a wider. So you will tell me a diagnosis as a wide QRS tachycardia. So you should not jump into the diagnosis of a ventricular tachycardia just looking at it. Because ventricular tachycardia has to be diagnosed with multiple other parameters looking at the ECG and clinical history. So this ECG is a wide QRS tachycardia which is looking every beat is looking same. That's the reason we call this as a monomorphic ventricular tachycardia. Unlike the previous one, where you have seen the morphology is changing in every way, it's a polymorphic ventricular tachycardia. When you see this like this is a monomorphic ventricular tachycardia. So this patient has a polymorphic ventricular tachycardia. So this patient required an immediate cardioversion because she had a ventricular fibrillation. So the drug of choice, so you have to remember that you have 2 drugs which are commonly used for ventricular tachycardia. Amiodarone, the problem with amiodarone is it's again a drug which can prolong the QT. So whenever you have polymorphic ventricular tachycardia with the QT prolongation, amiodarone is not indicated. So when you have a polymorphic ventricular tachycardia with a baseline QT which is normal, you can still use amiodarone. But in a polymorphic ventricular tachycardia with baseline QT prolongation, you are not supposed to use amiodarone because it will further prolong the QT and can make the VT incessant. Primarily use lidocaine as a drug, and other than that, if you have any other reversible factors, you have to correct it. So in this patient will go next. Usually polymorphic ventricular tachycardias are secondary to something acute. Usually they can happen secondary to a cardiac ischemia or a metabolic disturbance or secondary to a myocarditis or a infection of the myocardium. Infection or inflammation of the myocardium, they can produce a acute polymorphic ventricular tachycardias. So they can be associated with a prolonged QT. When you have prolonged QT and a polymorphic ventricular tachycardia, they are called tarsals. So polymorphic ventricular tachycardias are associated with long QT. Usually when you have a QT more than 500, so when it goes more than 600, we can expect tossets at any point of time. So whenever you see any patient in ICU or CCU or any patient who is sick, admitted with any other comorbidities, whenever you do an ECG, one of the very important things to look at is a QT interval. This is very important. A lot of time we forget to see the QT interval. There are very innocuous benign drugs which can cause trouble in these patients. A shot of pantoprazole can just prolong the QT and precipitate a tossets in a patient who is already a QT prolonged. And the patient who is at febrile illness has a baseline QT prolongation, you start them on a quinolones, you can just precipitate a long QT and tossets. I still remember an anesthetic student who just took a combination of azithromycin along with the antihistaminic and went into a VT storm because QT got prolonged. He had a baseline QT. There are patients who have baseline QT prolongation. We call them congenital long QT syndromes. They may not be manifesting. Suddenly they take these kind of drugs, the tossets will come. So frequently they are initiated after a pause. So we all know that whenever you have when you have two electrical beats or QRS beats, the next beats depolarization interval is usually designed with the previous beat. So when you have a long pause, the next beat is going to have a longer repolarization time. That means you have a long period at which heart is susceptible to ventricular arrhythmias. In ECG, one of the areas where the patient is very prone to cardiac arrhythmias are pro-arrhythmic period is a repolarization period or ST segment. Whenever you see a ST segment which is longer, otherwise a QT segment which is longer, these patients are more pro-arrhythmic, being that's the time most of the cardiac arrhythmias, particularly ventricular arrhythmias, are initiated. So most of the time this QT-induced arrhythmias are iatrogenic. You will see in patients who have a severe hypokalemia, hypomagnesemia, drug-induced, which is very common, or a combination of both. Patients have a significant hypothyroidism. These things can be seen. And there are patients, particularly in children, young age group, you will see a long QT syndromes, which can present as a causes. But what we usually see is in adult is an acquired long QT syndrome, which is secondary to drugs. There are some patients who will have a baseline QT always on a higher side. You give any drug which prolongs the QT, patient will precipitate a polymorphic tachycardia. There's a big list of drugs which can prolong the QT and cause causes. Most common culprits are usually antihistaminics and antibiotics, which we use commonly. And you should always be back of the mind, very careful, particularly in a cardiac patient who is on diuretics, careful about potassium and magnesium levels. I always say when you are treating a cardiac patient with diuretic, always try to keep potassium at least 4 to 4.5 in most of the patients. These patients are already prone to cardiac arrhythmias, and if you drop the potassium or magnesium to lower normal levels also, these patients can have a tossets. So most of the time, how you treat tossets is you remove the offending agent. If you have started a drug which has caused a tossets, you stop the drug, replete the potassium. I usually keep potassium more than 4.5 in most of the patients who have tossets. Magnesium, you may have to treat even though magnesium is normal, because it's very difficult to find intracellular level by looking at the extracellular magnesium levels. So you should always treat with magnesium. And if you see a patient who is a persistently hypokalemic, particularly a diuretic patient, you always interpret that patient as a hypomagnesemia. Until unless you cut magnesium, your potassium will not go up. Always try to increase the heart rate. You would have seen that any ECG, when the patient has bradycardia, QT always prolongs. In tachycardia, QT shortens. So whenever you see any patient with tossets, you always increase the heart rate. One of the drugs we use is isoprolol, which is very commonly available. You just give an isoprolol, keep the rate on a higher side. The patients will do well. Sometimes, if a cardiologist is available, you may have to put a temporary pacemaker and pace the heart at a faster heart rate. So this is about elongated syndrome. So another important thing, whenever I talk about elongated syndrome, I always tell you, like, whenever you are given a ECG, one of the most common thing you have to look at is most of the time now ECGs are computerized. They will tell you the QTC. So look at the QTC interval. If you have a patient with a reasonably good T waves, most of them your machines will give a good QTC interval. The one area where your ECG machines will be struggling is to find out where the T ends. So what I always say is, whenever you given a ECG and QTC is prolonged, you measure the QT interval by yourself, because measuring a QTC interval requires a formula. Nowadays everyone has a smartphone, and you go to any algorithm, MD-Cal gives a QT interval immediately once you enter the intervals. If you don't have an access also, you always look at the QT interval which is given in the ECG. You measure the QT interval by yourself. If the QT interval matches with the ECG directed QT interval, then QTC is going to be normal. Your ECG machine will never have a trouble in identifying RR interval. It will always have a difficulty in identifying QT interval. So if QT interval is measured correctly, your QTC is always correct. Another way is, just look at your RR intervals. If your T wave crosses half of RR interval, if you are going to measure if you look at the ECG and you are seeing a true ECG,
can you have an ECG so that
I will come down. So I'll show that. So it will cross the half of the interval. I'll show you the ECG when we see it. So these are the ways easily by looking at ECG you can see that QT is prolonged. So your next patient is a 60-year-old man with a CA stomach, person underwent total gastrectomy. 3 days after, he becomes breathless and was febrile, had a multiple ventricular ectopics with hemodynamic instability. He was intubated. Most of the common causes were ruled out. He was started on amiodarone infusion and slowly settled. After 24 hours, this is the ECG. So this is the first ECG before treatment. And this after they have treated it. So first ECG you can clearly see there is a QRS complex, QRS complex, QRS complex, and P waves are separately going on. You can see that your P waves are going separately and QRS complex is separately going up. With a wider QRS, we call as a ventricular escape. You can see a complete AV dissociation. Your atrial rate and ventricular rates are completely different. The patient has a complete AV dissociation. When you have a complete AV dissociation, one of the commonest cause, particularly patient has a bradycardia, is a complete heart block. The patient has a complete heart block where his atrium and his ventricle are not connected. Your AV node is disconnected due to multiple reasons. So atrium is beating on its mode and ventricle is giving an escape rhythm. So patient has a complete AV dissociation. After seeing that, a cardiologist has put a temporary pacemaker. That's the thing why the heart rate has increased. You can see a small spike in front of every QRS, which we call as a pacing spike. Your pacemaker is giving a spike, and after that, your ventricle is getting depolarized. So that's the reason you are seeing a small spike in front of every QRS complex. So you should always remember, most of the drugs you use as an antiarrhythmic, most of them are proarrhythmics. So all the patients, when you have a amiodarone infusion, you slowly overlap and taper into a oral IV tapering and followed by a oral. So you know amiodarone is a pretty long-acting drug. When you have stopped amiodarone also, the drug effect is going to stay there for a longer time. And amiodarone has two modes of action. So whenever you start an amiodarone as an IV infusion, the first one which comes in is a beta blocking action. So that's the reason when you have an AF with a fast ventricular response or any arrhythmia, when you give an amiodarone, it terminates or rate slows down. The primary effect which comes immediately is a beta blockade, followed by the your classical class 3 action, which is an antiarrhythmic action. So most of the patients, particularly elderly, who already have a significant conduction system disease, if you push an amiodarone, you can precipitate a bradycardia or complete heart block. So next is a 28-year-old female, post MVR, admitted with AF with fast ventricular response, significant congestive heart failure. Patient was started on a high-dose diuretic. Rate was well under control with amiodarone. Shifted out of CCU, and when they were shifting out of CCU in the lift, the patient had a cardiac arrest. Code blue was initiated, patient was revived. So this is the ECG, very classical ECG. You find anything abnormal in this ECG?
Someone can interpret anything.
The patient has converted to sinus rhythm. Right now, we don't have a AF here. I think you can see a P wave clearly. Anything else which is very striking in this ECG?
Just now you're telling him.
So he was asking me about also to show me an ECG. So anything is striking? Can you see a T wave here? Where your T wave is ending? Can you see there? In particular in this beat, your QRS complex T wave is nearly gone close to your P wave. Your QT which is pretty long. Can you see here? QT interval is pretty long. This is what exactly I was telling you. Whenever you see a ECG, you don't have, this ECG does not have any measurements. Most of the time your ECG would have given QT is prolonged. Most of the time, most of the computerized ECG would have clearly seen that QT is prolonged. Our QTC interval would have been in the range of 700 milliseconds. Here, if you don't have anything also, you just look at these two RR intervals. So when your T wave crosses half of this RR interval, then your QT is prolonged. Your T wave should end before half of your RR interval. So if normal QT, if this the T wave should have ended long before this. Here you can see this crossed and went close to a P wave. So very prolonged QT. So the patient, when they went to the ICU, patient had a Tassels. Tassels was the reason why patient had a cardiac arrest. So these are the reasons, multiple reasons why you will have a QT prolongation. So patient had a potassium not very low, it's around 3.6, and magnesium was pretty low, 1.2, and TSS was 15. So most of the patients who are in a critical care unit tend to have multiple reasons to have a longer QT. This patient has 3 reasons why her QT is prolonged. So this patient, along with this, they have started on a amiodarone infusion. So, always, lot of these patients have other QT prolonging, right? Like patient would have a pantoprazole, patient would have an antibiotic. Lot of these drugs will be there. So whenever you have a patient in critical care unit, always make sure the QTs are pretty good. So how to measure a QT interval? This measure from the start of QRS to end of T wave. It measures the total ventricular activity. That's what I was telling you. It is depolarization and mostly goes into a repolarization time. So QT is a dynamic interval which changes according to the rate. So you have to adjust it according to the rate. That's what we call as a QTC, which is corrected for heart rate. So we will measure RR interval, we will measure QT interval. You can see the place, most of the time your mid-precordial leads. Mid-precordial leads like V2 to V4 will have a proper T wave. If you go in and see, you find out a lead which is having a clear end of T wave, take that particular lead and measure the QT. And RR interval can be measured from any place. And once you have this, you have a Besset's formula which is available already. So only problem is the square root. So doing a square root in a usual calculator is difficult. So most of your smartphones, a lot of people I know have installed MDCal, which is a calculation for most of the medical related formulas will be there. You just put the numbers you will get. Otherwise, you just Google for a QT interval, you will get the Bessett formula and just put the RR interval in milliseconds and QT interval in milliseconds, then you will get a QTC interval. The easiest way is, as I told you, just look at your ECG, computerized ECG, what QTC is saying. If your computerized ECG is saying that QTC is 540, is a prolonged QT, then you go and measure the QT interval. If you measure the QT interval, if your QT interval is matching with what is your computer is saying, your QTC is always right. Because your computer will correctly diagnose RR interval. So only place it will struggle is finding the end of T wave. So if you have correctly identified the QT, your QTC is always correct. You know that one small square is 40 milliseconds. You count the number of small squares after the onset of QRS into end of the T. So that number of squares multiply into 40, you will get a millisecond QT. So this millisecond QT, if your ECG machine is properly calculating, then it is correct QTC. If 540 is correct. Other simple way I already told you, just look at the RR interval. When you have two QRS complexes, make a middle line there. Take a total, if the total duration is around 5 centimeters, just you measure with the scale or just look at your hand and make it half and see if your T is falling below that, before that, then your QTC is normal. If it is crossing that, your QT is prolonged, then you do a calculation and find out how prolonged it is. So, this is another patient, 26-year-old man, run over by a truck, managed in a local hospital in a trauma, brought to casualty for 24 hours later, had a significant head injury, crush injuries, and GCS is 10 by 15. Pressures are borderline 90 by 60, heart rate is 46. In ICU, intubated, stabilized. So this is ECG. Yeah. So one is whenever you see a ECG,
hyperkalemia. Then
see, that's what I was telling you. When you see an ECG, don't try to go to a diagnosis, always try to read an ECG. So you have a ECG where the baseline rhythm is bradycardia, right? Patient is in bradycardia, heart rate is low. Second, you look at the rhythm. Can you see a P wave here? You don't have a P wave at all. You don't see any P wave at all. Second, look at the QRS width. QRS is prolonged, QRS is wide. So you have a wide QRS rhythm, which in bradycardia, you hardly see a P wave. One of the earliest sign of hyperkalemia is loss of P wave, because atrial depolarizations gets affected first. So you won't see a clear-cut P wave when you see a hyperkalemia. And second important thing, as you told, is looking at a T wave. In a mid-precardial lead, you will see a tall, peak, tented T waves. It is always suspicious of a hyperkalemia. It's not the only reason you will get a tall tented T waves, but it's one of the common reasons when you see a tall tented T waves. So when you combine all this, you don't see a P wave, bradycardic, tall tented T waves, no P wave, wide QRS. So this is, in a clinical scenario, this is a hyperkalemia, and potassiums are going to be pretty high, because you have already lost, the patient is nearly moving towards the other stages of hyperkalemic crisis. It slowly will develop a sine wave soon. So his creatinine was 4.5, potassium was 7.1. It's a muscle injury, so CPK was elevated. So this is how your potassium level will cause changes. As your potassium level goes up, you will see changes in the ECG. So a lot of time people say that you may be able to see potassium levels just looking at the ECG and changes, although it's not always true, but most of the time, as I told you, seeing that ECG, you know potassium is more than 7.5. So patient is moving towards what we call as a sine wave. When the potassium crosses 8 plus, you will see a sine wave pattern, and patient is going to arrest if you are not going to correct the potassium soon. So consider potassium derangements in any arrhythmia in ICU. Potassium, hypo and hyperkalemia is the most common metabolic disorder you are going to see in ICU. Focus on underlying dysregulation in all the patients who are in ICU. So potassium has a huge role in cardiac depolarization. It is involved in multiple phases of depolarization. That's the reason your potassium changes have a significant proarrhythmic effect. So if you look at ventricular and potentials, you can see potassium has a multiple action throughout the action potential. So if you see a electrolyte imbalance, these are the common electrolyte imbalance you will see in ICU: hypokalemia, hyperkalemia, hypocalcemia, hypercalcemia, and hypomagnesemia, and others like hypo and hypernatremia are taken. So hyperkalemia, typical tall tended T wave of hyperkalemia. You will have tall peak wave. By tall, we mean it should be more than 2 big boxes in the precardial leads, or more than 1 small box in limb lead. So this T wave should be taller than the QRS. Your T wave should be the QRS complex. So you will see that how the potassium level causes serial changes in the ECG. At 4, T is looking good. It's tall, going up, going up. At higher levels, you will slowly see that T wave beats the QRS complex, and slowly it will become a sine wave pattern. So the first thing you will see is the ST segment disappearance. The T wave grows and P wave goes off, and sine wave comes in. So they all happen at multiple levels. When you have a loss of P wave and your QRS becoming wider, then you are looking at a patient with a very high potassium and you need an immediate treatment. So the last patient, I think. So 52-year-old male, post-EMI, severe respiratory dysfunction, class 4, CC with high dose diuretics, fatigue and vomiting. This is a day 1 ECG. This is day 2 when the potassium is around 2.1, and this is on day 3 when the potassium has come down further. You can see QT is significantly getting prolonged here. So whenever you see this is what I told you. You look at this patient, 2 QRS complexes. If you put middle of the QRS complexes, your T should be finished before that. And here you can see the T is finishing before that. But in the next patient, next time when the QT, when the potassium goes down, you can slowly see that QT is getting slowly prolonged, and QT is nearly crossed it, and now we have a T and P wave which are nearly fused. It's a significant hypokalemia. So hypokalemia we already discussed. You will see initially a SH signal depression, slowly T waves flatten and they can join the U wave. U wave gets larger than T wave. In the last ECG you have seen that the U waves have become bigger than the T wave, and QT interval lengthens and PR interval also can interval. When you have interval can increase when you have a significant hypokalemia. This is how it looks like. When you see a hypokalemia, you will have a prominent U waves. Once it goes up, once further and further potassium lowers, you will see a U wave beating the T wave, and you will slowly see only TU complex with a prolonged QT. So this is how it looks like stage by stage. Where potassium is normal, U waves slowly overtake T, and after that it goes up and becomes a single long QT complex or QU complex. Hypo and hypomagnesemia, they don't have separate patterns. Most of the time you will see a QT prolongation like what you see in a hyperkalemia. So serum levels hardly correlate. When you have a significant hypokalemia or a prolonged QT, it is worthwhile giving a magnesium because you cannot identify exact magnesium levels by just looking at the levels of magnesium in the blood. And elevated levels, hypermagnesemia is more of a neurological problem than a cardiac issue. You will not see a major cardiac issues. This is a 54-year-old man, post-CA bladder, present ED with abdominal pain, weakness and fatigue. So, anything significant here? So you can see here, this is again a QT issue. His calcium is 14. Patient has a significant hypercalcemia. So hypercalcemia, when you see a calcium going down, you will see a QT getting prolonged. Hypocalcemia will prolong the QT and hypercalcemia will shorten the QT. So you will see here the QT interval is normal here. Once you will have a hypercalcemia, the QT will shorten, and in a hypocalcemia you will see a prolonged QT. So these are the usual patterns you will see. Both hypo and hypocalcemia are lesser arrhythmogenic than potassium. Potassium among all electrolyte imbalance is more arrhythmogenic. In a single patient, particularly if your patient is on diuretic, you can have a multiple electrolyte imbalance. The same patients will have a hypokalemia, hypocalcemia and hypomagnesemia. So all the diuretics will deplete all three electrolytes. So it will have a combination of these. So this is a summary of what you will see in a electrolyte imbalance patient. In a hypokalemia, you will see a decreased T wave amplitude with a T wave inversion. Slowly your ST segment depression happens with a prominent U wave, prolongation of QT interval or QU interval, and ultimately patient will end up in a ventricular tachycardia torsades. Hyperkalemia, mild, you will have a large amplitude T waves, a peak or 10 T waves. Slowly your PR interval prolongs. You will see a decreased P wave amplitude and disappearance of P wave, and QRS becomes wider and wider with conduction blocks appearing, and in a severe hyperkalemia you will see a sine wave pattern or a ventricular fibrillation. In a hypocalcemia, you will see a prolonged QT interval. Patient can develop a ventricular arrhythmias secondary to prolonged QT interval, including tarsus. In a hypercalcemia, you will see a shortening of QT intervals. Even with hypercalcemia, patient will develop bradyarrhythmias. You don't have unique electrocardiographic features of a hyper and hypocalcemia except they change the QT interval. So with this, I'll close my discussion. If there are any questions, I'll be happy to be part of it. Thank you.
Thanks, Nani. I think basic concept what he is trying to say is always correlate your ECG with your cardiac action potential. You see, whenever there are changes in calcium, which usually correlates with your plateau phase, we have changes in the ST segments, either ST elevation or ST depression or ST flattening. And potassium most commonly correlates with your repolarization abnormalities, which corresponds to your QT intervals. So when you see an ECG, it's not a paper with a tracing. You always interpret what is actually happening in a muscle there. So what is the action potential, where it is happening, whether it is the sodium channel, calcium, or in the potassium channel. So I think it's a initial. I thought it was it is only for the basic topic, but so it's not a spoon feeding program here. We don't go from anatomy starting like this. You see, taking from case scenarios into your basics. This is what will actually be in your mind, rather than taking a straightforward lecture, talking about your SA node, AV node, and all those things. Very nice topic. Very nice discussion, Lawrence.
I think that Dr. Narak wanted me to talk about how to start basics of ECG. I think the primary thing which you do ECG is to treat your patients. Ultimately, I felt that case scenarios will trigger more interest in you to understand how important ECG is to see. Particularly, these are non-cardiac situations. Whenever we do an ECG, we always look at cardiac arrhythmias or MI or acute coronary syndrome. This is the times when you think about an ECG. None of them are, maybe except few, are cardiac patients or are non-cardiac patients who we should be able to pick up ECG just looking at the ECG. Not only these things can be picked up just at your monitor. You don't have to do a 12-lead ECG also. Just a running monitor, and nowadays most of the monitors will see a QTC also. You will see that if you switch on the monitor and allow the monitor to pick up QTC, the QTC will be lively coming. You will see a QTC interval coming consistently. So you have to train yourself to treat the basic problem. So ECG is a very good indicator of underlying electrolyte issues or other issues which is happening in critical care patients. So we know ECG is very useful in acute coronary syndrome, very useful in cardiac arrhythmias, but even on non-cardiac patients, there is so much of utility for a general physicians and a critical care physicians and anesthetists to have a look at the ECG, which is very important. Thank you.
I think many a time, I have received 2-3 patients with an ST elevation MI, most commonly turning into an hypercalcemia. So with that ST segment slightly going up, so with chest pain, which is very classical of an hypercalcemic syndromes. So they come with chest pain with an ST elevation, atrophy being negative. We just need to rule out. I think.
Good morning to all. It was a very good talk by Dr. Lawrence. This ECG club will be very, very useful for all general practitioners and their PGs, PGs especially, and especially interactive sessions will be very useful. And a good effort by Dr. Narak. Thank you.
Sir, your words.
Thank you. I think first I should thank Dr. Revathi and Dr. Narak for taking this initiative to do this topic, which actually might be not only useful for the physicians but also for all activities. Doctors for practicing and mostly for day-to-day practice. I think we should all take up this and long run it will be useful not only for us but all the practicing doctors. Thank you.
Yeah. The JMK account initiative that will be useful. So, keep the programs, so that everyone should attend this and benefit from this.
Once again, I thank Dr. Lawrence. He is my junior in BSc. We have been here for the past 5 to 6 years. He has been with me for assessing all my pacemaker cases here. He's a lovely friend. Thanks, Lawrence, for accepting the invitation from me.
Honoring Dr. Lawrence by our HOD, Dr. Somsuthan, sir, please. Honoring. Chal, Dr. Chal. Photo.
Hey.
Sir, do you want to? Chal. Chal. Right. Remove it. Everyone sit, please. Honoring Dr. Vigneshwaran sir, Nagaraj. Honoring Dinagaran sir. Somsuthan sir. Honoring Pranav sir, Dr. Shaktivelan. Honoring Pandirajan sir by Nagaraj sir. Honoring Nagaraj sir, Dr. Kunasingh sir. Honoring Dr. Somsuthan sir, Dr. Muthukumar sir. Muthukumar sir.
Dr. EMS sir will honor Muthukumar sir, senior. Vote of thanks by Dr. Somsuthan sir, Head of Department of Medicine.
Thanks for the organizer for this opportunity given to me to deliver the vote of thanks. Sincere thanks to the chief guest for his presence, inaugurate the program, and his presentation of various case scenario with the ECG changes. And again, I would like to thank each and everyone. Each and everyone for the participation for this grand success of this event. And again, my sincere thanks to the Dr. Yeshwaramurthy and Dr. Narajan for the effort to initiate such kind of events in the throughput ECG. Thank you to all.
Final word. So the program or the ECG forum will be in this hall every Saturday, third week of a month. The timing will be around 3 to 5. It will end with the high tea. You can bring your cases, or if you want, you can have your ECGs, their difficult ECGs in a slide. You can present it. We can discuss. We'll let you know. or if you need some topics, probably a week before we'll ask your opinions. If there are more than 2 to 3 ECGs, probably we'll discuss the ECGs, or else we'll have a small topic followed by the number of ECGs or interesting cases which you see in your daily practice, or in our daily practice also we can learn. So ECG learning is an art, so it doesn't come in a day or two, because each day is a day in an ECG with respect to cardiologists as well as with practitioners. So I think go on join raise ECG, because ECG as initially said, it's a simple tool and a very valid tool with the background of a good clinical history. Thank you. Thank you.
Any suggestions, questions, welcome. ஒரு முக்கியமான விஷயம், சக்திவேலன் சார் வந்து 2 years சொல்லிட்டு இருக்காரு. இதோட இன்ஸ்ட்ருமெண்ட் வந்து சக்திவேலன் சார் கொடுத்த ஒரு ஐடியாவும் கண்டிப்பா தேங்க்யூ ஸோ மச் சார்.
Whether the ECG club activities, every Saturday you are telling them 3 to 5.
Every month, third Saturday.
Yes, monthly was very good.
Monthly was.
3 to 5 is okay, very good, very nice timing. The thing is, whether you can go by for particular topic, for example, chamber announcement today,
Okay.
with case discussions.
Yes, sir. Because now if
Coronary
you,
artery disease with the case discussion of some other case also they are coming with some other cases. Like that, we can go for the systemic way. It's good.
yeah, a systemic way is always in good sir, but the thing is you will forget when you go out. When you put 5 cases of LVH and tell all those things, after a week if you find some case in your clinic, you will not be able to find it. But when you go with your history, and or else we can do like this. We can systematically, in the sense, what you say is, or rate finding a rate abnormalities a day, arrhythmias in a day, and then we can just do it. So we'll just take it. And if some good cases are there, you can ask them to come here. We'll have even an echo here. We'll post the echo videos here, so that it will be full-fledged.
You already mentioned the topic that those who are coming to office with the preparation.
Okay. That we'll post it probably the second week. Thanks, sir. Thanks for your initiation, sir.
Any suggestions, sir? Any other suggestions from anybody else? So,
You can put it in your.
in the forum. Thank you, Dr. Muthukumar, sir, Dr. Hari Krishnan, and Dr. Shivakumar, Dr. Selvaraj, sir, Dr. Somasundram, sir, Dr. Pranav, Dr. Pandirajan, sir, Dr. Bhagavat Kumar, Dr. A. Karthik, Dr. Dinesh, Dr. Jamuneshwaran, Dr. Preetika, Dr. Adhav Selvam, Dr. Muthuswamy, Dr. Saktivedan, Dr. Ganesh, Dr. Satyakala, Dr. Tirumurugan sir, Dr. Nirmal Kumar, Dr. Sri Vasanta Kumar, Dr. Sharath Kumar, Dr. Arun Kumar, Dr. Gogol Siddharth, Dr. Sacheshwaran, Dr. Unasen sir, Dr. Santosh Kumar. Thank you all. We adjourn for breakfast.
One more thing, whenever you bring your cases, have your ECGs and always bring your chest X-ray also. And don't forget it.